sleeve that you know this is the level of tibial base plate? Koi bhi, no problem.
Two things, the anatomical landmarks in a primary knee is, one is meniscus. That is important. If you don't, there will be some remnant of meniscus in and around either lateral or medial. That is one. And then you can always, yeah. Your base plate has to be at the level, maybe slightly higher, maybe couple of millimeters, should be at the level of meniscus. It should.
Lower, because I'm going to add plastic on top.
So it not above the level of the meniscus. Not above the level of the meniscus.
Between the head of the fibula and where you want your base plate?
Fibula you palpate.
Yeah.
And just be sure that your joint line is around 2 centimeter above it.
So
that is the best line.
joint line means the plastic. Now I'm not at the plastic stage yet. I want to know where is my base plate going to sit in relation to head of the fibula. That's my question. That's why I hammer it. Hammer karta rahu ya chhod do.
You have to be at least 2 centimeter above the head of the fibula. And you can easily palpate during your
Joint line is 2 centimeter above the head of the fibula, presuming that your plastic will be 8 to 10 millimeter. So your base plate has to be about 1 centimeter above the head of the fibula. That gives you a fair idea about joint line. Up okay? Okay.
Yes. So good evening. I'll be speaking on application of metaphyseal sleeves in revision TK. So there's a case here. If you can see, there is a loosening of a femoral component completely, and it could be even when you remove the implant, you may find the tibia also has a huge defect which can be taken out very easily. And when you see this kind of material, which all final debridement and gutter clearance, what you apply the revision principles, been taken care of, you leave with these kind of defects, metaphyseal defects on both the sides. You hardly have a epicondyles both end, and there is no bone left out. This is another example of that. So you need to go back to your classification first to define how you are going to manage this case, and accordingly you need to select the line of treatment. That's one. What kind of implant you're going to use it, whether you're going to use a sleeve, cones, or if I'm not sure about the hinge, if you need to use it. You need to also be careful about understanding the classification of zone fixation. Out of these 3 zones, epiphysis, metaphysis and diaphysis, you need to fix very solidly in 2 zones, which is minimally important to give a good stability and long-term results in fixation. So you can go back and read about this zonal fixation in revision TKR. The metaphyseal sleeves I'm talking about, they're parallel to this. There are also the cones available, but metaphyseal sleeves gives huge biological fixation, has been proven to give a long-term results with good stability. There are only one company which I know makes the metaphyseal sleeves, both on tibia sides and femur side. It can be used with or without the stem, depending upon the type of defect and bone available there. There is a technique of using these sleeves. So usually once you have taken off all the implants, clear the gutters, you have done the debridement, then you need to first establish the tibial platform, then go to the femur side and also balance your flexion and extension gap. This is a proper technique which if I'm able to demonstrate here, I'm not able to show here. Actually there's a video, complete video, but it's just a second. I'll open the video here. Yeah. So you see that first you have to first slow that. Then there's a metaphyseal sleeve construct with a stem. You determine the size of the stem. Then finally you have a different kind of sizes and approach along with the stem, because the stem should be absolutely endosteal fitting cut. And you have to also take care of a rotation of the sleeve. So it cannot be very loose sleeve. It should be a very tight, snugly fit sleeve. Because of the lack of time, it cannot be loose sleeve. You can see this here. And finally, when you put your sleeve inside, the trial sleeve inside, when you establish, it has to go 1 or 2 millimeter below the platform. And if you see here that you should be able to completely solidly lift up even the tibia, that's called the fixation, and you can establish the tibial platform. So this is how you should be using a sleeve there. Now, when you go to the presentation again here, this is, क्या हुआ?
It's okay. वीडियो दिखा नहीं है,
वीडियो दिखा नहीं?
इधर नहीं चल रहा।
Oh, sorry. निकालो। इसमें वहाँ नहीं दिख रहा है। मैंने सेपरेट चलाया ना वीडियो। नेक्स्ट स्लाइड देखो, फॉरवर्ड नहीं हो रहा तुम्हारा स्लाइड। नहीं, कोई बात नहीं, विल नॉट शो द वीडियो, दैट्स फाइन, परफेक्टली फाइन। आई विल जस्ट शो मी द पीपीटी लगाओ उसको। पीपीटी लगा दो सिर्फ।
One caution I want to give.
And of course the brooch, when you do it, it cannot be a loose fit, as I was talking about it. It has to be very tight, snugly fit with proper rotation. You have to establish the tibial platform, and when you finally put the sleeve, it should be a very solid fixation. And you see here, you can, अरे बीच में तुम्हारा भाग रहा भैया. So I'll not run the video, rather I will just talk on the slide. Excuse me, PPT आ नहीं रहा है.
इधर दिखाओ यार.
Okay, so you need to basically determine the size of the stem with the scratch fit. You have a different trials of stem and the sleeve, if you see here, and you have to put a proper broaching with the sleeves, and you need to see that your sleeve is absolutely solidly fixed into the metaphyseal area along with a stem. And of course you need to also establish the tibial platform. So if you see here, it has to be at least 1 millimeter or 2 millimeter down. Now I'm not going to show the video here. The same way you need to also check on the femoral side, and you have to prepare the femoral sleeve area like the same way. First you have to do the size of the stem, which has to be again the scratch fit. You need to be careful about the femoral bow, so you cannot have a very long stem which can lead to a problem. Sometime you might have to use an offset stem then depending upon the size of the sleeve, which again has to be broached to be a very solid fixation. You can then cut the distal femoral cut, the posterior cut if it's an issue, and if you have to bring the joint line into correct position, you may use a distal augment or a posterior augment, and again do a trial before you establish the flexion and extension gap. Now, okay, so once you have done the preparation, also you need to see that you have established a proper flexion and extension gap, and there is a proper way of putting a sleeve along with a stem. So you do not leave the sleeve and stem to the company person in the hand. You do by yourself, and basically you have to align these properly. The defect in the metaphyseal area can be bone grafted, and do not apply the cement inside, so that it will interfere with the sleeve osseointegration. And once you have done that correctly, the correct way of doing is cemented, you can put a final implant and you can establish excellent knee, and of course you have to always be taken care that you are maintaining the joint line. This is the post-op of the same patient which I have shown you, both the side. And if you see on the lateral, the patella is in right position, so you maintain the joint line and it gives you an excellent function. These sleeves can be used also along with an instability patients like in hyperextension with different kind of knees, and you have to be very careful. Idea of presentation is that you should know how to gently use the sleeves, and you should not burst the canal, because in Indian scenario we have very small femur and very small tibia, and most of the achy, then the DPO I think has it, and the smallest sleeve sometimes have a problem in putting in some bone. So you have to be a little careful about using the sleeve. Currently, I am the president of Indian Arthroplasty Association, so at this platform, I request all of you, those who are not member, to become a member, and your town is hosting next year the IACON, so please join in a large number next year. Thank you so much.
Thank you, Dr. Sanjeev. Thank you very much. So I think we can have some discussion on bone defect management. My question, Sanjeev, to you is, you are always tempted to use that bigger size sleeve.
Yes.
Because whenever I do I use a sleeve and I look at the check X-ray, I find there was a lot of bone. I should have probably gone to the next.
Yes.
So in the next case, I have a temptation to use the next and the next.
Yeah.
Where is the stopping point?
So actually it was not in the video that once it is a tight fit, like you do the unsymmetric stem, and one of the video we have shown it, even Vijay Bose has shown it, the moment you put an uncemented brooch inside, okay, and you move with even a small towel clip, your leg is also moving. So the moment you find with your hand is stable, you lift up the tibia with the sleeve inside, that's the point. So if in the case there is also cemented sleeve comes in, okay, so you can also use a cement in one of the smallest size sleeve.
I'm talking about uncemented.
Yeah.
So what happens if I use the next?
No, you should not be tempting to. You may be raising then it up. Okay, so suppose if the metaphyseal fixation is good, 1 or 2 millimeter if it is high, it can be left like this, because you have to have two zone fixation. So with solidly fixed, 1 or 2 millimeters is fine. It cannot be 5 or 6 millimeter up.
So the problem is that the size of the sleeve, like the one DPU has, is 29, which is cemented. Then it's directly is 37, which is uncemented. So there is no size in between. And then there is another which is I think 41 or 41. So there are sizes which are 4-5 mm apart. So it's not just 1 millimeter or 2 millimeter like broaching that you do.
Yeah.
It's 5-6 mm apart. So once you are able to lift the tibia, probably that's the way you.
That's the one thing. Second thing, now you have also the cones available, and there are, apart from the one company, the Zimmer, there are 2 Indian companies also having a cones availability there. So I think you can have a mix and match of both the things with you, and then you can use whatever you're comfortable. But definitely you cannot hammer so hard that you have a periprosthetic fracture intraoperatively.
I think two word of caution for beginners, particularly when you're revising and there's a cement inside the canal. That cement tends to misguide your drilling and sleeve and everything. And you can be very dangerous when you are doing everything as per guidance of the cement. And I always take an X-ray image on the table, because I want to see the tip of my rod, because it is just the last bit when you are hammering. If your canal is curved and your rod is going all the way up, just one more pat and there is a fracture there. So when you are preparing all these things, I think it's a good idea with the canal, while you're reaming the femur and tibia, to see whether you are in the center of the canal, in the part here and part here. Otherwise, sometimes you can put it in a wrong way and can create fracture, tibia fracture as well as femur.
Yeah, intraoperatively imaging, lot many people hesitate, but in such situation, or most of the time, you should have your CM in the theater. You should
see-
take at least one shot and check.
You should see a CM. I think that's, I agree with you.
The problem with these defects where you're using the sleeve in primary is that the tibia will be bowed and there may be some stress fractures already existing in the metaphyseal diaphyseal region. That is where
See,
CM
patience is the key. You have to be very
CM
careful.
becomes very, very important, imperative actually, because in the way of going a bigger size stem,
Yeah.
And also the trend is now using shorter sleeve, shorter stems. Because when you put long stems all the way there is an entity called end stem pain which comes up. Because if you're too tight at the fixation point here and here, patient has pain there, which is something you can't treat. So shorter stems, particularly cemented ones, if they can serve the purpose, I think that's a good
So
idea.
basically, when you have a, sequentially you are doing a scratch fit stem and then you're putting a sleeve, broaching, you know what you're going to use it. You should not be tempted to use, nahi, ye thoda sa loose lag raha hai, abhi mere ko aur tokne do. No, not at all. The moment you have a scratch fit in your hand, you have to be very patient, and I'm sure that none of the revision surgery can be done in a very fast speed and tempting way. You should be very careful about it.
Anybody wants to share any comments on use of how to add bone? Management of bone cement, your tip. One tip. One tip about management of bone defects.
Yeah, I mean, I think with all these implants, you can do away with bone grafting. I think you don't really need allograft. So I think that's one big advantage of using sleeves and cones. With the sleeve, you need to cement. With the cone, the problem is that if you use the smallest size cone, you can still cement the sleeve. But once you go one size higher, you have...
In which? In the sleeves. Yeah, sleeve, the only smallest size is cemented there available, otherwise there's not. Yeah. Stem is uncemented, always.
Anybody, any questions or comments? Any tip you have to tell us from your experience? You have no experience. Thank you. I think we can close this discussion for the time being. You can sit. So let me invite next.
Good evening, and it's a privilege to be here, and my thanks to Dr. A.S. Prasad and Dr. Vishal Agarwal for the kind invitation. So I shall be talking about the role of rotating hinge in revision arthroplasty. So this is, and sometimes in primary situations as well. So the hinge is the last level of constraint, and the situations where you need to use it is if you have either a complete MCL insufficiency or a combined insufficiency of the MCL and LCL. So that's one situation. The other is if you encounter an Eng type 3 bone defect where the epicondyles are also involved, which means that the attachments of the collaterals are gone, giving rise to global instability. So that's where you need to use a hinge. So briefly looking at indications of rotating hinge, you have severe rheumatoid with global instability, complete MCL insufficiency. In hyperextension also, it's a good idea to use a hinge, because otherwise most other constraints, they fail. Neuropathic joints, septic revision with severe bone loss, fracture non-unions with necrosis, and of course bone tumors. And we'll try to see examples of all these instances. So the hinge basically can be either a fixed hinge. This is the ultimate level of constraint, but they are not very popular today because they had a short life. And the reason was that the torsional forces were transmitted into the stems and they resulted in early loosening. So what we use today are rotating hinges. Here there is an uncoupling of torsional forces between the joint line and the metaphysio-diaphyseal region, and this definitely lengthens their survivorship significantly. That again, two types, the condylar loading hinge. Now here the load is transmitted through the tibial and femoral condyles. An example has been shown here. But this means that you need to achieve excellent fixation of the hinge, and the condyles need to be reconstructed so that they can be loaded. The other is the axial loading hinge, where the load transmission goes through the axis of the limb. The condyles are not loaded, and here actually you don't need to reconstruct the condyles to that extent, and most of them can do well with the axial loading. So this is an example of a severe bilateral rheumatoid with complete global instability. There is, it seems, a component of neuropathic joint. These are the lateral views. And when we opened it, then it was a completely disrupted joint, which again, there was a large metaphyseal defect which we filled with the sleeves, as we saw in the previous presentation. And this is the SROM Noyles hinge which is in place. And this is the post-operative X-ray. The other side, we got away with a lesser degree of constraint, and the lateral views. But that was not the end of the story. Then we did not use a stem on the right side, and then there was a molding there of the bone, and eventually the patient presented back with a fracture, and then we had to once again go in and excise this bit of it completely and replace it with a distal femoral replacing prosthesis using the same hinge. But eventually the result was good, and she had a fairly good range of movement. So this is another example of severe rheumatoid with global instability. Rheumatoids seem to go one way or the other. They either become stiff and ankylosed, or they become completely unstable. And this was managed with an axial hinge. This is the link hinge. This patient got a fracture, so we had to put in a screw. I'm sorry about the length of the screw. So another example, place where you might have to primarily use a hinge is a severe valgus Krakow type 2, where there is a complete insufficiency of the medial sleeve. And this is the X-ray. So you have to remember that on the medial side, there's just one restraining structure, and that is the MCL. So if that is gone, then again you need to use a hinge here. This is the axial loading hinge which has been used in this patient, post-operative X-ray, and this patient did pretty well. But these are cemented hinges, and they need actually large quantities of cement. So this was a neuropathic joint with a severe destruction. This patient was diabetic, and on opening there you see extensive bone loss and destruction. Again, it was an axial hinge was decided. We built up the defect with bone cement. But you can do that in an axial loading hinge, but you can't do that in a condylar loading hinge. And this is the post-operative X-ray, after which the patient was mobilized. Infected knee with a stage 1 revision done, with severe bone necrosis, as you can see on the X-ray, on the operative photograph. This is the trial hinge in place, and this is a post-operative X-ray after a cemented hinge has been used. This is another case. I'm sorry. This is a preoperative X-ray where there's been a complete failure of union of a distal femoral fracture. The bone segments were completely necrotic, so it was decided not to attempt another osteosynthetic procedure, but to go in for a hinge. This is the trials in place. These are the implants which went in, and this is the post-operative picture where the distal femur has been replaced with a plastic implant. Again, another failed case of fractured periprosthetic fixation, and here again the entire segment was replaced with a distal femur replacing implant and a hinge. This is the hinge in place, the implants, and the post-operative X-ray. So this patient was a multiple myeloma patient with involvement of the distal femur. She was obviously on chemotherapy, and instead of trying to take a chance here. We decided to resect the entire tumorous portion with a hinge. So this is another situation where you can use it. This is a giant cell tumor of the distal femur with the MRI picture, again treated with a distal femoral replacing implant. So in summary, severe global instability can sometimes be encountered even in primary situations and very often in revision. Complete incompetence of the MCL and recurvatum are indications for a hinge implant. Also, very severely deformed fixed knees can be straight away converted into a hinge. Fixed hinges are the extreme limit of constraint but have problems of loosening. Rotating hinges achieve decoupling of the torsional forces and therefore they have a longer lifespan. Condylar hinges load the condyles and therefore require a stable metaphyseal fixation and reconstruction of the condyles. Axial hinges transmit weight through the mechanical axis and do not load the condyles, require a good diaphyseal fixation. I thank you for a patient hearing.
Thank you, Dr. Vidi.